So I'm going to speak on osteocoronary lesions, an interesting case we had. This is about an 84-year-old gentleman, hypertensive, presented with frequent episodes of heart failure and effort angina. In fact, he was having NYHA class 3 to 4 symptoms. And his ECG showed a sinus rhythm with LVBB, LVH, and echo showed multiple regional wall motion abnormalities with severe LV dysfunction. His Euro score was 2.9. This is the ECG. So we thought because of he had in fact 5 years back an angiogram which was reported to be normal. In view of his symptoms, we thought we'll do a separate angiogram again. So we took a femoral root, and this is the right coronary artery. You can see there's a proximal to mid RCA, there's an 80% lesion, and ostial RCA was quite tight. And when we engaged the catheter in, there was significant pressure damping. So we went ahead and pre-dilated the lesions with 2x15 non-compliant balloon, and then we got also the ostium, and we got good flow inside.
I'm sorry for interrupting. Did you show the left coronary? Yeah.
I'm going to show next.
Oh, okay.
In fact, we did a radial angiogram, and then we switched because the procedure we had come to femoral. So then we placed the stent from the ostium of the right coronary artery across the lesion, the mid RCA, just at 2.548 DES, and we post-dilated with a 3x12 non-compliant balloon. So precise stent positioning is critical when performing ostial PCI. It's necessary to say that the stent is within the radiopaque markers on the stent balloon. And thus a proximal marker must be positioned proximal to the ostium in any ostial lesion. So this after stenting, and we got good results. You can see the ostium of the RCA is nicely flared up. Then we went to the left coronary system. Here on the left coronary system, again, you can see in the ostium of the left main and proximal left main, there's an 80% tight stenosis. And way down in the mid LAD, there's another 70% stenosis. Circumflex appeared normal. So we stented the mid LAD with a 3x38 science and overlapped from left main with the 3.533 science. We wired the circ actually, but it was pulling the catheter inside and causing pressure damp. So we removed it and directly stented. We post-dilated the stents with 3.515 NC non-compliant balloon. And again with 4x15. The left main was post-dilated with 4x15 non-compliant balloon. We did an IVUS, and there was a little bit of malopposition in the left main. So we went ahead and post-dilated once more with a 415 non-compliant balloon. We got good results. So again, ostial lesions are very interesting because they can occur within 3 millimeters of the origin of the coronary artery. It's often missed in routine angiograms, and they're classified as ioto-ostial, non-ioto-ostial, branch-ostial. These orange figures are ioto-ostial, green non-ioto-ostial, and blue is branch-ostial. Most common etiologies are atherosclerotic ioto-arthritis or mediastinal radiation. The challenges of these lesions are that they are funnel-shaped, they're fibrotic, calcific, they're resistant to dilation, and prone for elastic recoil. And the problem is placing the stent. Very rarely you get that first picture when you get an ideal position to place a stent. So either you can miss the ostium, or you can, if you place the stent, you can cause carinal shift, or you can protrude too much of the stent into the vessel. So the difference between ostial left main and ostial RCA is that ostial left main usually has got a low restenosis and stent thrombosis risk. Although left main has a larger external elastic membrane, The right coronary artery, interestingly, has got a small MLA, but a large muscular tissue around it. So they are more prone for repeat stent, restenosis and stent thrombosis. Complications we find are guide-induced dissection, geographical mess, excessive stent protrusion, plaque shift, loss of guide position, failure of stent expansion, etc. Unfortunately, my IVUS is not running. So the interesting thing was that after the procedure, it took about 3 months for him. There was significant relief of symptoms. There has been an improvement in ejection fraction, and he has had no further hospital admissions. So the key to good result is precise stent location and also a delicate balance between complete plaque scaffolding and avoiding excess protrusion aorta. Euroscore 10 is an independent predictor of MACE. This guy had a Euroscore 2.5. So use of IVUS confirmed, IVUS confirmed a precise stent location, adequate stent expansion. And when asked, most patients will prefer PCI over surgery.
Okay, thank you so much. The case is open for discussion.
May I ask one question? Had this patient had any form of like ischemic evaluation? I mean, I was looking, but I'm not 100% like, and why did we send the left main again?
Pardon?
Why did we send the left main?
A significant disease in the left main. We also did an IVUS. I'm not able to run the IVUS. So this guy had NYHA class 3 to 4, and he was getting repeated ischemia-induced LVF, was getting frequent admissions.
Admissions for unstable angina?
Unstable angina as well as heart failure.
Okay.
I was just wondering about the order of things. I think it's just the way that the presentation is constructed. Did you image the left system before you stented the RCA?
Oh yes.
Okay, that's. I figured that. I just wanted to make sure.
Yeah. Diagnostic. I didn't show here.
Okay, and
this heart team approach. I'm sorry. I was just wondering because you know I ended up getting
this
like,
guy. We had a discussion. In fact, though I didn't mention it, the patient was 84 years old and he was very much against surgery. So and we thought we could get good results with.
The other thing is, I think from where I'm sitting, it's just difficult to see the details of some of the angios. The ostium of the right, I found it a little difficult to appreciate, but you could certainly back your guide out and take a little bit of a non-selective image and then also just use IVUS or something to confirm that osteal disease. But you mentioned there was dampening as well there.
It is damping, and damping can occur when the catheter size is bigger than the vessel or it's going and directly hitting the vessel wall.
Okay.
But we did an IVUS for that also. My IVUS pictures are not running.